Okay, I am going to introduce Cheryl to you. Does anybody know Cheryl? No, you're new to everybody. That's so awesome. Okay, well, it's an honor to introduce Cheryl. She's very near and dear to our hearts. She has delivered all 3 of our children. She is, I can't say, like, she's one of those women, I know I'm going to probably embarrass her, but I couldn't say enough wonderful things about her because we don't have time, and it's not about me talking to you about her because she wants to share midwifery with you. But she has been an amazing just woman in our lives because we have a heart for home birth, we have a heart for healthy women and children, and she's always calm, cool, and collected, but she's incredibly professional. She's unbelievably talented in what she does, and if you're looking for a midwife, she's amazing. She's probably getting really, really dizzy too. But anyway, she's going to share her heart about midwifery and answer some questions, and I will turn it over to Cheryl.
Sure, thank you. Well, welcome. I don't see anybody that I recognize, so thanks so much for coming. The title of this class is the midwifery model of care and how it is impacting women and babies around the world. I'll touch a little bit about how midwives are trying to improve outcomes in the United States, and then I'll use some other countries as examples, kind of run through just some basics about the midwifery model of care and how that's different from the medicalized form of care if you're going to see an OB in the hospital. Just a little bit about me. I am new to Kansas City in the last 5 years. I grew up in Maryland and have had 6 children. I have had 3 with an OB and then 3 with midwives that ran a freestanding birth center in Maryland. So love being in Kansas City, and it's a great place to practice midwifery. One, because of the support for home birth midwives, which is what I do, as well as we have great collaborative care here, which just means we have good access to OBs and perinatologists when we have a situation that is outside of the range of normal. So basically, I just want to talk about the midwifery model of care, and it involves monitoring the physical, the psychological, and the social well-being of the mother throughout her childbearing cycle. My goal is to provide the mother with individualized education, counseling, prenatal care, continuous hands-on assistance during pregnancy, during the prenatal care, labor and birth, postpartum, and newborn care up to 6 weeks after the baby's born. Obviously, I'm going to try to minimalize medical and technological interventions if they are not necessary or needed, but at the same time identifying and referring the woman to an OBGYN or a perinatologist if it is necessary. And that's where you see the best outcomes, is when we have that collaboration between midwives and physicians. Ironically, the US is the worst, ranked the worst in the last year or so in the industrialized world for maternal mortality. So if you think about that, here we are, this great country, we have all this technology, and we are literally ranked at the bottom of the other industrialized countries. We are behind Iran, Turkey, and Libya, to be specific. Some of the best countries where you see really good outcomes are the countries, especially in Europe, where the midwives handle most of the prenatal care, labor and birth, and then the physicians are called if a problem arises. One of the best countries that has released a lot of information and ranks highest is actually Holland. About 70% of their population is born at home with midwives, and again referred out to specialists only when absolutely necessary. Let's see. Just to give you statistics of why I got into home birth and what I love about it. About 1,000 women die every single day in childbirth. African American women are 3 times more likely to die in or a result of birth than white women. And so that's another piece that midwives are working towards changing, because there is a huge disparity even amongst the African American population. Okay. Let's see. So why is this important? Well, the midwife-led continuity provides care mostly from the same midwife or a team of midwives during pregnancy, birth, and the early parenting period. And many women value this. So that's the other thing in the research. You'll find that many women are saying that their overall experience during birth and postpartum has improved by having a midwife versus an OBGYN. The evidence here, so I got my research from both Medscape, the Cochrane Review, and then the World Health Organization. And in that, they did about 15 studies involving 17,674 women and babies. And this study was completed in January of 2016, so it's fairly recent. And it included women that were considered low risk. So not looking at women that are having twins, repeat C-section, even triplets, no pre-existing conditions like diabetes or high blood pressure. So this also, we want to think about the low risk category when I'm talking about how midwives improve outcomes. All the trials involved professionally qualified midwives, and no trial included models of care that offered home birth. So we're not even looking at the statistics from home birth. We're just talking about midwives in hospital, birth center locations. So the main benefits that women who received midwife-led continuity of care were less likely to have an epidural. In addition, fewer women had episiotomies or instrumental births, so that means they were less likely to, if everybody doesn't know what an episiotomy is, that's when the provider would cut the perineum, which is the skin between the vagina and the rectum. Less likely to have forceps or a vacuum extraction or even a C-section. There was increased chance of the woman having a spontaneous vaginal birth and no difference in the number of cesarean births. Women were less likely to experience preterm birth, and I think the reason there is with the midwifery model of care, you get a lot of one-on-one. So for example, my prenatal time is usually 45 minutes to an hour versus 15 minutes in a doctor's office. So I spend a lot of time asking and talking about, what's your diet like? What's your stress level like? What's your sleep like? Just even simple, how much water are you drinking, which can really make a difference in impacting a healthy pregnancy. One other significant piece here is that the women were more likely to be cared for in labor by midwives that they already knew, and this increased the likelihood that they would have a vaginal birth without complications. So the hope and the goal here in the US and then worldwide is that women would be offered the midwifery model of care if they desire it. It's not just, I found out that I'm pregnant, I have to go to a physician, that they would have that opportunity to make an informed decision and decide, especially if they're low risk, what they would prefer. Let's see. Okay, so now I just want to talk about, there's something called the International Mother-Baby Friendly Initiative. You may have also heard here in the US there's something called Mother-Baby Friendly Certification, and so that is just some guidelines of what we strive for in order to improve the outcome of a healthy mom and a healthy baby with long-term breastfeeding. So the first piece of the midwifery model of care is that every woman should receive respectful care, feel like she's listened to, heard, and that she's able to make decisions, informed decisions, whether it's to agree to a certain type of care or to actually decline once she's thought about and discussed with her family what is going to be best for she and the baby. I touched on it a little bit, but just the individualized care where every woman is different, whether it's your first baby or your fourth baby. Every woman's stress level is different. What kind of family support do they have? So taking all those things into consideration throughout the pregnancy, during the birth, and the postpartum. It's not just a physiological occurrence. It is also a psychological. So, and again, in that, hopefully she'll feel supported and heard and have a better experience. The other big piece of what the midwives do is we all believe with our heart, soul, and mind is that pregnancy, childbirth, and the postpartum period, along with breastfeeding, is normal process. You all know that God created women, and in that He created them to give birth. He created them to nourish a baby. And so that is our goal, is helping the mom figure out how to do that. Even when she may not even understand that her body knows how to do it, she just has to learn as she's going along. And obviously this can occur if she feels supported by her caregivers and her family system. The other piece is that women should receive full and accurate and unbiased information about the harms and benefits of each intervention or alternatives that are being offered. I think the biggest piece here is midwives, especially that practice in birth center and home birth or out of hospital settings, are really focusing on supporting the normal physiological process, which would involve alternative measures to coping with pains during pregnancy and then obviously during birth. The studies have shown that the more that you can support that normal physiological process with water, a doula, good family support, massage, eating and drinking, moving around, changing positions, that you're going to have a better outcome than just going to the hospital, sitting in a bed and getting an epidural or possibly even some narcotic IV pain relief. And obviously those things impact the baby as well, which is another part of what we do. We're not just thinking of the mom, we're also thinking of the baby and how this experience impacts the child. Birth practices that affect the mother-baby physiologically as well as psychologically, we've talked about that a little bit. You can do everything right in terms of physiological support, taking her blood pressure, listening to the baby, talking to her about her nutrition. But if you don't take into consideration, again, who she is as a person, how she's handling the pregnancy, what's going on in her life, then you can miss a huge piece of how to support and nurture and encourage them in this time. The other thing that I love personally, just because I do home birth, but you can have it in a birth center, and I have seen it on occasion in a hospital, is just creating a very supportive environment for giving birth, and that is going to be different for every woman. Some women prefer to labor fairly quietly and alone. Others like to have a team of people around them. Some women, can sway and do a few different position changes, maybe take a shower and have a baby. Others need more hands-on support, whether it's lots of position changes, birthing pool, and more verbal encouragement. So there's lots of variations there in how, whoops, sorry. how women will actually give birth. And that also pertains to positions for the actual birth. So there's, you know, you don't have to just give birth laying on your back. You can squat, sit on the toilet, lay on the bed, sit on the floor. Huge variation there. Another piece that's very important in this midwifery model of care is including the father. And I think sometimes I've heard from parents that have had hospital births, and I know my husband experienced this with our first 3, is just the hospital setting can be fairly intimidating, and they may not have a relationship with the doctor, and so one other piece is a lot of dads express just feeling more included, more a part of the process, and maybe even being able to catch their own baby, so, which is a big piece because he has to be the primary support after the midwife is finished their care, and now it's just the mom and the dad raising the baby. One of the other pieces here is that women can safely give birth outside of hospitals, in birth centers, home, when skilled and effective providers are there, and you have referral for collaborative care if needed, and that would usually be in the event of an emergency. Although all midwives are trained in emergency practices, and we use those skills, we practice those skills, but in the event that it's something that's outside of our scope, then we have that availability to either transport to hospital and involve a higher skilled practitioner. Some of the other things that I think that people and midwives love to offer during their prenatal care, and the clients will come back and say, well, this was really helpful, is we really focus on education. So again, it's not just you're getting shuffled through an office setting, 10 or 15 minute visit, and you forget to ask your questions, or maybe your questions aren't answered thoroughly, but we spend a lot of time on education, nutrition, and then promoting that clean, safe environment for when the baby comes. Another big piece of the improving the outcomes in the midwifery model of care, like I mentioned before, is just having access to higher skilled OBs or perinatologists in the event that that is necessary, and identifying those, especially if they become life-threatening situations. The last piece that midwives love to focus on is you've gone through the pregnancy, the prenatal care, the birth, and now you have a baby in your arms, and we want to establish great mother-baby attachment, and our goal is that you would be breastfeeding for hopefully a year, just because that is a whole nother talk in and of itself, but how breastfeeding impacts the mother-baby attachment and the child's lifelong health. It's not just health for 6 months or a year or 5 years, it's gut health for your entire life. So I just want to say thank you for being here, and I'd love to just open the floor for questions. I don't know what everybody's familiarity is with midwives, or if you know any midwives, anybody born with midwives, but I'm available to answer any questions. Yes?
So insurance will also cover your costs?
Not always. So I'm what's considered a certified professional midwife, so I'm an out-of-network provider. If you're wanting to bill insurance, the best thing to do at the start of care is we call your insurance company and do something called a verification of benefits, and we find out what your out-of-network deductible is, and will they cover home birth with a CPM. Some do, some don't. Depends on the plan. Yes?
I don't really understand the difference between a midwife and a birthing center. Like, what are the main differences between home birth and...
So a birth center is run by midwives. Sometimes they might have a physician on staff. That varies from state to state. There's also two kinds of midwives here in the U.S. There's something called a certified nurse midwife, and there's also a certified professional midwife. The certified nurse midwife went to nursing school and then did a graduate program in midwifery. Most of their clinicals, unless they opted to do out-of-hospital setting, were in hospitals. The certified professional midwives here in the U.S., the majority of them work at home birth. There are a few birth centers that employ CPMs. So in that, the biggest differentiation there would just be that the CPMs are usually more skilled at doing out-of-hospital birth, whereas the CNMs are more able and capable to do prescriptions. If you needed an epidural, if you need IV fluids, that kind of thing, they're already established with a hospital.
So you're a CPN?
I am,
okay.
yes. Yeah. Go ahead.
What is the protocol if you're having multiples?
So the question is, what is the protocol if you're having multiples? And that really varies, because with twins there are varying degrees of risk, if you want to use the medical term. Twins in a first-time mom would be considered riskier than twins in somebody who's had babies before. And then from there it goes to what kind of twins. So there's something called mono twins, which means they share one sac, identical. That would be considered riskier versus fraternal twins, where they're in two separate sacs and maybe even have two separate placentas. And then when you're in labor, depends on if the first baby is head down. And then on top of all that, it depends on what your caregiver's skill level is. So there are a few OBs and midwives that specialize in vaginal twins. That is something that they have had a lot of experience in, versus somebody who's never done twins, then they maybe don't have the experience to know how to identify complications.
At what point do you determine those types of, if you're able to use it?
Right. Well, so obviously you know right off the bat if the mom is a first-time mom or she's had babies before. That's one piece of it. Usually you can send them for an ultrasound anytime between 16 and 20 weeks, and that will tell you if it's 2 sacs or 1. And then based on that, it would be more towards the end of pregnancy. And with twins, one of the biggest risk factors is preterm birth. So hopefully getting the mom to like 36, 37 weeks, that would be another piece. Yeah. Sure.
So after the baby's born, how long do you guys stay with the mom to ensure that good breastfeeding is established? Because
Sure.
I feel like with her,
Yeah.
I had her in the hospital, but like I needed so much help
Right.
those first 24, 48 hours,
Yeah.
like the whole time, because I was so weak and tired. And
Yeah.
so like, how long do you guys stay with the mom after she gets
So
pregnant?
every midwife is different. I personally stay about 2 hours after the birth if everything's normal. And during that time, we are assisting with breastfeeding, making sure the baby's latched several times. Usually in that first hour, if it's undisturbed, the baby will latch itself, and then might most likely latch again after we've done the newborn exam and weighed and that kind of thing. I also do a 24-hour home visit, a 3 to 5 day home visit, and then you come and see me at 2, 4, and 6 weeks. But obviously, if you have any issues in that time period where we're not face-to-face, you can call, schedule an extra visit. I have lactation consultants that I refer if it's something that's outside the range of what my normal is. So, and just remember that the first 10 days are challenging for any mom with breastfeeding. And then it can take several weeks to build the milk supply. Yes.
About 1,000 women die each day.
Yes. Yeah.
Is that all right?
That's worldwide. So yes, they die from, the number one cause of maternal death in labor is actually a postpartum hemorrhage, which is the baby's been born and for whatever reason, and that could be intervention that was unnecessary, versus just anemia or a big baby that displaces the uterus, and now the uterus is like, whoa, I gotta shrink down and I'm tired and I don't know how to do that. So postpartum hemorrhage is one of the #1 reasons. And then they've looked at, in the US, one of the big causes is women dying from secondary or infections following a C-section or a hemorrhage following a C-section. Yeah. But you can have other issues like embolisms, preeclampsia that turns into eclampsia. So there's several things that can cause maternal morbidity.
So as a midwife, how often do you see preeclampsia and all that?
Preeclampsia, from what I've studied and learned, is kind of the longer you practice, the more you might see it. It's about 1 in, if you care for 100 women, you might see it, I think this is right, 1 time. If you care for 10,000 women, you might see it 10 times. But I've diagnosed it twice in the last 5 or 6 years, and then we referred to hospital and went in and had a baby, and good outcome. So it's recognizing what is considered preeclampsia. Eclampsia is that next stage where you're really in the danger zone of possibly the mom is seizing, and if you haven't delivered the baby by then, you risk losing both the mother and the baby.
So you will refer those to a medical doctor?
Oh yes, yeah. Because at that point you need to have a baby. That's really the only cure for it. But again, there are ways to prevent it in terms of stress, diet, nutrition, that kind of thing. Yes?
When's your first time that you see a midwife? What do you recommend?
It really depends on what the patient wants, but typically my clients come to me between 8 and 12 weeks. If they've had miscarriages, they might want to start sooner, like 4 to 6 weeks. But if everything's normal, I usually see people about 8 and 12. We can get a heartbeat around 10 weeks.
Okay, I was going to ask what kind of equipment you use.
Yes.
Do you do ultrasounds or what?
I usually refer out for ultrasound at least 1 time, and that's typically between 18 and 20 weeks. I do have a Doppler. I also have a fetoscope, which is the old-fashioned stethoscope in the ears with the little horn that you put on the belly, and we can use that beginning around 18 weeks. And I like that because that's the true heartbeat, whereas the Doppler is an echo. So, yes.
What type of tests do you do prenatally? Like, do you do the gestational diabetes and things like that the hospitals do? And like blood work, how often do you take that?
So the question is, what kind of prenatal testing do I do? Every midwife is different. And in this, most of the CPMs would say they offer true informed consent. The medical medical is to do initial blood work when the patient first starts care between 18 and 12 weeks. Then you would do blood work again at 28 weeks, which include the gestational diabetes screen if you want that. And then do another, what they call complete blood count, about 36 to 37 weeks. Just there we're looking at hemoglobin, platelets, which are your pieces that you want to watch to help prevent postpartum hemorrhage. And I offer all those.
Ultrasound, the test you mentioned, so you said 12 to 15 initial blood works, then again at 28?
28 weeks, which is usually when we do gestational diabetes. You would do another complete blood count at that point. And then again at 36, 37 weeks. If you're giving birth here in the US in a hospital, they will do blood work when you go to the hospital to give birth. I don't do that as a home birth midwife. I go by what your blood work was around 37 weeks. And if there's no abnormalities there, then we just assume you're going to stay healthy until you have the baby. Yes?
I don't know if you mentioned this, but is there people who use the midwifery model versus going through the hospital? Are there statistics that show that the mothers are less likely to get postpartum depression through a home birth or through a birthing center versus in a hospital? Is there a correlation?
I don't know if there's been a study done directly related to postpartum depression, but I do know the studies, they ask a question, it was called a listening to mothers survey, and they've actually done that one twice. You can find that survey through the Cochrane Review, but that women reported higher levels of satisfaction if they gave birth with a midwife at home or at a birth center, or had less intervention, and felt like their OB really listened to them. So I'm sorry, I don't know the answer to the question about the postpartum depression. On that, I do screen for postpartum depression between 4 and 6 weeks on all my women.
How do you do that?
I use the
just had a baby and they're concerned, and
Okay.
so I just was curious how.
If you Google, there's actually a standardized depression scale. It's about 10 questions. I can give you the link after if you want that.
You
And
do that 4 to 6 weeks out.
yes. And then we obviously refer out if we have a mom who's depressed.
What do you think causes, like my mom had it with my older brother, but is that,
Postpartum depression?
is it like spiritual, I mean, like what do you feel like causes
Oh, I think it's
that?
very multifaceted. So that's the other thing with postpartum depression. In the Listening Mothers survey, women who feel like they were not listened to in birth, maybe it was, I'm in a cut and episiotomy, and the mom said, no, please don't do that, and they snipped anyway. You really need this drug to help you relax. No, I don't want that. I want to use my comfort measures of moving around and changing positions. No, here, we're going to give you an epidural. That kind of thing. So I think that can contribute to the postpartum depression. The breastfeeding really has a significant impact on postpartum depression. And the reason is when the baby breastfeeds, your body makes something called oxytocin, which is the love hormone, which is relaxing, helps you attach to the baby. And so if you're not having a successful breastfeeding experience, which could be a result of not enough support, not good education, being separated from the baby. You'll hear, I think, some women who have babies in the NICU have higher levels can have more postpartum depression, and that would be understandable because it's extremely stressful to try to care for a baby that is in the NICU, even though it may be necessary.
How do the costs compare?
How do my costs compare?
Well, not necessarily you, but an overall cost to have a midwife versus the typical.
So in the US, you can pay anywhere from, I think it's $7,000 to $20,000+ to have a baby in the hospital. Whereas birth center, it's about $5,000 to $7,000. Obviously, this is going to vary depending on region. And I believe most of the midwives in the Kansas City area charge anywhere from $3,000 to $4,000. Yes, yeah. 3 to 4 for the home birth midwives is the norm in this area. Yes. Yeah.
And a lot of women report better experience.
Yes.
With midwives as well.
Yes. If they keep coming back, that's a good sign. Yes.
Right, after the baby's born, what is your standard practice? Like in the hospital, they do shots immediately, the vitamin K, everything, and now we're hearing about delayed cord clamping,
Right.
etc. So what are your practices?
So the question is, what is my practice following the birth of the baby? And I like to think of that first hour postpartum as your golden hour and really minimize talking. We want to wait till we have a placenta, which again, if we can keep the room kind of quiet. Obviously there's excitement and joy, but I'm kind of more in the background, letting the parents and whatever family is there be excited about what's just happened. Keeping the baby skin to skin for that first hour is pretty significant and high on my priority list. Once you've had a placenta, I usually don't cut or clamp the cord until about an hour after the placenta has delivered. Everybody's different. Some midwives do it when the cord stops pulsing. I like to do an hour just because I feel like that's less fiddling with the baby and the mom during that time. There's something called a Lotus Birth, and again, this is patient preference, but you cannot cut and clamp the cord and just leave the placenta in a little bag or a basket wrapped up until the cord actually falls off the baby.
What's the benefit of keeping it longer?
Worldwide, they're showing that the baby gets all that blood flow from the mom, and one of the studies showed that babies 6 months postpartum had higher levels of hemoglobin versus babies who got the cord cut and clamped right away. The other piece is their baby's still getting oxygen through that umbilical cord, so if you have a baby that actually might need help at birth, I don't cut and clamp the cord because I want the baby to get that oxygen flow, even though it might need some extra stimulation to get it breathing. And any other? Yes, go ahead.
Are you talking about water birth?
Oh, yes, one of my favorites. So she's just asking about water birth. Water birth is becoming pretty popular. It's been around for a long time, but the benefits of water birth is getting into a deep tub that is warm but not too hot, not too cold. Actually acts almost like an epidural. It really helps the mom cope, takes the edge off, and the babies that are born into water are usually much calmer because when the head comes out into water, they went from being an amniotic fluid to water. They're not stimulated to breathe until they hit the surface. And again, they're still getting oxygen from the cord, so we don't really worry about a baby coming out and being what we would say depressed. And the other thing is in my training, I can tell when a baby's head emerges, is that baby doing well or does that baby need to be delivered quickly? And usually that has to do with the color. Are they making movements? Like you might see them open their mouth and some fluid come out, which is a normal physiological process in the birth. And then you can even see them, sometimes they'll move their shoulders in order to rotate to get out the rest of the birth canal. So I love water birth. Obviously there are things that I'm trained to make sure that everything's normal, because you wouldn't want a water birth if you were expecting or knowing you had an emergency on your hands. The biggest piece there with water birth, again, is just the postpartum hemorrhage. So that would be one reason to get out of the tub immediately, is if we have a baby and blood or bleeding that is beyond normal, you'd say, let's get you out quickly. So you can do water birth in a bathtub, but I have what's called a birth pool, and it's a blow-up pool that's about 3 feet high and almost 4 feet oval shaped, and we put a liner in it, and you get a hose and an adapter, and we fill it up, and the mom gets in there as she's getting closer to delivery. Yes?
How do you make sure the water is pure with the water birth? Like, do you have a filter that the water goes to?
No, it's the same as it's the same as taking a shower or a bath, because we're using the water from your home. It's not like we're getting water from some unknown source. And then you're going to buy a new garden hose. We're not going to use a hose that's been sitting in your garage for a couple of years, used in the yard. Yeah.
What percentage of your births are water births?
It's pretty high.
Because otherwise it's just like in your bed, like wherever you choose.
Right. I would say close to 90%. Every once in a while I'll have a mom that is just like, that's too much work and I give birth fine, I'll take a shower, and then I might have the baby in the bathroom or on the bed or on the floor or in the hall. It really just kind of depends on where they start getting that urge to push and where they want to have the baby. Yes?
What do you think about, I know like a lot of women are starting to take their placenta in capsules. What do you think about that, and is that something that you practice in your care?
So that is patient preference. It is becoming quite popular. And I refer to, there's a couple women in the area that do placental encapsulation.
Do you see a lot of benefits from doing that?
I mean, the moms say that it's beneficial. So when I was having my children, I had never even heard of it. So I can't speak to it personally.
So what is it?
Placental encapsulation is after the baby's born, within a couple of hours, somebody takes the placenta and dehydrates it. And then they take that dehydrated placenta and they put it into capsules, and the mom can take that during the postpartum period or for as long as she wants. Yes. Yeah.
For the nutrient value.
Nutrition value, preventing postpartum depression. It has hormones, obviously. Do you have another question?
Do you do any teach them exercises before they actually have the baby? You know, there's all these classes.
Right.
They used to have, I think they still do.
So the question is, do I teach any exercises before the mom has the baby? And the question is yes and no. So we talk about birthing positions, exercises that are helpful during pregnancy, like swimming, walking. You know, what was your normal exercise routine before you had the baby? There's also a great website called spinningbabies.com that gives various positions that you can start getting into a little routine of doing at the end of pregnancy, and that helps with optimal positioning of the baby for birth. And then childbirth education is very helpful as well. Time's up? Okay, go ahead.
I was going to ask, what does a doula do that you don't do?
Okay, great question. So the question is, what does a doula do that I don't do? I was a doula for 12 years before I became a midwife. So a lot of what I incorporate just in labor would be similar to what I used as a doula. So a doula is a woman that is with you during labor, and also you can have a postpartum doula. She provides informational, emotional, and physical support. The informational support is helping you figure out various interventions, kind of writing a birth plan, what you're hoping for to happen during the labor and the birth and postpartum. The emotional support is, the studies have found that when you have that continuous support of somebody who's not your midwife or doctor, or even a family member, that you're less likely to need intervention. So I think it's just that one person focused on telling you you're doing a great job, this is normal, and then the physical support would be things like recommending position changes, shower, water, birth ball, massage, that kind of thing.
How do you spell doula?
D-O-U-L-A. Yes.
Thank you, Cheryl.
Thank you. Great to see everybody.